I've been given a controversial topic, active surveillance and focal therapy, which I subtitled Negotiating the Gray Zone. And I have three disclosures. I'm a consultant MIR Scientific. I've had funding from Exact Imaging and Profound. So what are the issues in this area? And there clearly is a gray zone, and I think practitioners disagree about where the boundaries of that zone are and how you should manage patients in that zone. So how does the risk of residual or persistent grade group 2 or higher disease compare between patients treated with surveillance and patients treated with focal therapy? What's the risk to the patient of untreated grade group 2 disease in the patient on surveillance? How reliable is imaging in surveillance follow-up and post-HIFU, which obviously introduces artifact? There's a fair bit of data that HIFU or any energy-based intervention introduces MRI artifact and therefore reduces the specificity. Can MRI and biomarkers replace biopsy in the follow-up of these patients? And what's the current and future role of molecular biomarkers in follow-up? So a lot of issues. The goals of active surveillance, just to recap, for de novo grade group 1 patients, identify higher grade cancer and risk reclassification. For the historically about 35% of patients diagnosed with grade group 1 we know harbor higher grade cancer. Most of them grade group 2, and many of them still indolent, but nonetheless, and of course about 10% will have grade group 3 or higher, and they are very much at risk. That's been the Achilles heel of active surveillance since the get-go. We're better at it now, but it's still an issue. And then for the patients with grade group 2 to 3, the goal is identification of clinical progression while the disease is still curable. So find that cancer and treat it before the patient develops metastatic disease during the period of surveillance. And we know from multiple prospective cohorts, there's at least 12 of them in the literature. The total number of active surveillance patients being followed prospectively in these variable cohorts is somewhere around 15,000 now, with many having been followed more than 15 years. So we know that the likelihood of progression of metastatic disease in patients on surveillance is somewhere around 0.1% in the Hopkins cohort, which was very restrictive, to around 3% in our cohort, which was more inclusive. It's low by any reasonable standard, but not zero. With focal therapy, the risk of failure is remarkably consistent between modalities. Obviously, it reflects patient selection, but it's somewhere around a third of patients have a local recurrence after focal therapy. So both, the message of this is that with surveillance and with focal therapy, you have a risk of unrecognized persistent disease or untreated disease if there's focal therapy has treated the contralateral side. That's actually remarkably similar. So focal therapy, the appeal of focal. And as an advocate of focal therapy, I am frankly staggered by the persistent resistance to the concept of focal therapy in the urological community. I really don't understand it. The argument seems so compelling. Many clinically significant cancers are indolent. Radical treatment risks over-treatment. We know, for example, from SPCG4, the pivotal radical prostatectomy versus no treatment study from Scandinavia, major benefit in grade group 3 and higher, and in their last New England Journal publication, which was 29 years of follow-up, no benefit in the 3+4 of surgery. Very compelling argument in support of more conservative management for 3+4. Little to lose, because in the patients with particularly grade group 2, this is, even if it's not indolent, it's generally slow growing, so you have time to intervene with a conservative therapy that preserves quality of life and still have time for salvage afterwards. It's the paradigm of lumpectomy for breast cancer applied to prostate cancer clearly makes sense. Lots of tissue to preserve. A typical candidate for focal therapy has got a 1 to 2 cc cancer and a 40 cc prostate, so you're talking about 5% of the tissue directly involved by cancer. Clearly, preserving tissue matters. You can preserve tissue, they get better functional outcome. And increasingly, as we move to imaging before biopsy, we're finding these patients who are found to have what seems to be a solitary lesion identified on targeted biopsy, where they look like ideal candidates for focal therapy. And another appeal of focal is the profusion of methods. So at least 6 different ways to direct energy to partial gland ablation. And then you have the misuses and the risks of focal. Many patients have multifocality, so this is clearly a challenge, but there are patients, despite this tendency to multifocality, who are treated with focal who have a phenomenally favorable outcome. The limitations of imaging and targeting, we've heard something about that. You can miss lesions. The issue of monitoring, there's no consensus. Do patients need serial biopsies, at what interval, etc. The biology of response of residual diseased injury, I'll come back to that. This to me is an issue that is completely unaddressed and is something to potentially be concerned about. The effectiveness of salvage treatment, there's a number of studies that show, not surprisingly, you take focal therapy failures and treat them with surgery, they have a higher PSA recurrence rate than patients treated primarily. Lack of level 1 evidence, I'll come back to that too. And I've listed profusion of methods and approaches as both a strength and a weakness. Because on the one hand, you have many alternatives. On the other hand, it's kind of a mess. Which is better? Which technology should be applied to which patient? We really have no solid evidentiary base for addressing that. And I don't really need to tell this audience about the multiple techniques that are out there using heat, either HIFU with ultrasound energy, TULSA, the MR-guided transurethral approach or MR-guided transrectal approach, laser ablation, freezing, ionizing radiation, focal brachytherapy, electroporation. There's been a number of reports now of partial prostatectomy. Frankly, it makes no sense to me, but people are doing it and reporting good results. And then you have the options of focal partial hemi, hockey stick, subtotal. So which you do in which patient, it really comes down to provider preference at this point, which is not the way it should be. One of the issues for me is what I call snake oil medicine, which means an ineffective treatment for a self-limited or clinically insignificant disease. So this was very popular in the 19th century. Whatever you had could be cured by snake oil medicine. So there's the risk that you have an innocuous intervention, doesn't have a lot of quality of life effects. If you're using it to treat a clinically insignificant cancer, that really is the criteria for snake oil medicine. I think the implication of this is that we're not talking about treating grade group 1 cancer with focal therapy. That's by and large not the indication, with perhaps a few exceptions. I mentioned this issue of tissue response to injury. And the analogy to here, which I think is quite compelling, is what is called accelerated repopulation in the radiation field, which is a well-recognized phenomenon. The idea is normally you give ionizing radiation, you induce double-strand breaks, you get apoptosis, cell cycle arrest, etc. But if that, for whatever reason, the radiation is stopped prematurely, the patient has some comorbidity that prevents them from being able to get it. There's a technical problem. The radiation technologists go on strike, whatever. It stops, you can get, instead of death, you get genomic instability and more aggressive repopulation, accelerated repopulation. So this is a well-recognized phenomenon in the field. But you think you replace radiation with a sublethal energy dose. So let's say you treat the cancer that you know about, but it's actually more extensive than is recognized on the imaging. So at the edge of the treatment zone, you have an area that's been injured but not destroyed. and you have release of cytokines and growth factors, and essentially have the same phenomenon that these mitogenic molecules may induce genomic stability and exacerbate the cancer. This is purely hypothetical. There's no evidence for this one way or the other, but I think it's certainly possible that you may take a fairly indolent grade group 2 cancer and make it worse if you don't treat it adequately. And just one example of this from the lung cancer field, that injury-induced fibrosis may alter the cancer biologic phenotype. So this is recognized to occur, that an association of fibrosis with cancer progression in lung cancer. So just something to think about, maybe something to evaluate for those who are in a position to do so. And then I mentioned the issue of salvage versus primary treatment. So this is one study from Rafael Sanchez-Salas that compared patients who had radical prostatectomy after focal HIFU to primary surgery, and not surprisingly, the PSA recurrence rate is considerably higher in the salvage population. Selection clearly plays a role in this kind of analysis. You're taking patients who've already failed compared to patients who have not demonstrated failure. But, again, something to be concerned about. We offer focal therapy with confidence that if they fail, we'll be able to salvage them, and that is true only to a point. And then you have the issue of MRI. And I'm not going to dwell on this. We've heard quite a bit. Gorgeous talk by Samir Tunisia on some of the issues around pathologic myths. This is one study from UCLA that showed that in patients who had multifocality, this was a radiology to pathology comparison with whole mounts in about 600 patients. In the patients who had multifocality with cancers less than 1 centimeter, something like 80% of them were actually missed on MRI. So this represents a challenge for the focal therapy world, that you can count on the fact that you may miss cancers. There's ways around this with template biopsy, which I don't believe in. That's another controversy, or with thorough systematic biopsies, but still potentially an issue. And then also the concern that MRI in particular tends to underestimate size. So this is another study just showing that whereas the mean size on pathology was 2.4 cubic centimeters, the estimate on MRI was smaller by about a third, 1.6 versus 2.4. So I think a basic precept of focal therapy is you treat beyond the lesion that you see. And then one more study emphasizing the limitations of MRI in men on surveillance, this Chestnut study, that basically a third of men with a stable MRI at 3 years were upgraded to Gleason to grade group 2 or higher, despite the stable or even improving MRI. And biomarkers, 9 different commercial biomarkers now available: blood, urine, tissue. Cost varies between about $500 for most of the liquid ones to $4,000 for the tissue-based one. Area under the curve for finding significant cancer, consistently somewhere around 0.7 to 0.9. They've never been compared head-to-head, so these numbers should be compared with caution. Having said that, the one with the highest area under the curve at the moment is SelectMDx, urine-based assay. So these are all trying to identify the presence of significant cancer in the surveillance patient or in the focal therapy candidate, and clearly they have some role. And I would say the sweet spot for the tissue-based assays, which we don't use much in Canada at all, but if you're going to use them, it's the patient with the grade group 2 cancer who you're trying to decide on active surveillance versus focal therapy or some other type of radical therapy. So to cut to the chase, who are the candidates for partial gland ablation versus the candidates for surveillance? So the sweet spot, I would say, is grade group 2 from a targeted biopsy of a solitary unilateral lesion on MRI, systematic biopsies negative or show low volume grade group 1. I don't know why anyone would object to an initial approach of focal therapy for a patient like this, because most of them have a very favorable outcome and their quality of life is superior. However, still this is very much a controversy, and focal therapy, to the best of my knowledge, has not made it into any Western world guideline as being an accepted standard of care, which I would say is inappropriate. Not as sweet a spot, but also candidates, the patient with grade group 3 and a solitary lesion. The issue here is less wiggle room in terms of being confident that they're not going to progress to advanced disease between the period of initial treatment and the time you've decided that they've failed. But these rather energy-based therapies are certainly effective at eradicating the cancer that you know about, even if it's higher grade. Multiple lesions. So the patient with 2 ipsilateral lesions stands to reason if they've got some multifocality, they may have more. But again, some patients who fall into this category are being managed this way successfully. Solitary lesions crossing the midline. The evidence seems to suggest, and this is my own interpretation of the data, that if you treat up to half of the prostate unilaterally, you get very little comorbidity. As soon as you cross the midline, the comorbidity goes up significantly. So some of these solitary lesions do cross the midline. The quality of life benefits may not be as great. What if you don't see a lesion on MRI? Samir addressed this. These patients, unilateral grade group 2 cancer with no target, I think they are reasonable candidates. You know which side the lesion was on. You can treat hemiablation despite the absence of a target, but again, they're not perfect. And finally, grade group 1. So you're probably aware that the NCCN just went through a major controversy. They changed the recommendation for grade group 1 from surveillance to being preferred to surveillance being one of 3 therapeutic options: surveillance, radiation, or surgery. And the result was a massive Twitter storm and pushback by our colleagues. And within a month, they have reversed this. I've never seen anything quite like this. It's gotten quite a bit of attention in the lay press. So they're back to active surveillance being preferred, but the whole thinking was that there are patients with grade group 1 who should be treated, and I think we all acknowledge that. The patient, for example, who's got BRCA2, these patients have an 80 to 90% chance of progressing to higher grade cancer over a 10-year period, and I think they should be treated. The patient who is young, whose prostate is loaded with grade group 1, we don't see that too often. Most young patients, say under age 50, when they're diagnosed, they have a few microfoci, but once in a while you get these bad actors whose prostate is loaded with grade group 1, and we don't have any real confidence that their natural history is going to be as benign. So I think there are these exceptions, and that's what drove the NCCN to modify their guideline. And then finally, the patients who I don't think focal therapy is a good idea, but some would, the real advocates: high volume grade group 1 unilateral disease, young patient, clear target on MRI. I manage these patients with surveillance, but there are advocates for treatment. Or the patient with really high-grade cancer who's got a small solitary lesion with no evidence of multifocality. This, to me, is a major gamble. These are lethal cancers, but you can certainly eradicate a small solitary lesion. The problem is they may have more that you don't know about. So I think the patient selection comes down to multiple factors: which treatment, what to treat, lesion versus focal versus hemi versus subtotal. No one anymore is treating just the lesion. I think focal therapy involves treating the lesion plus at least around 5 to 10 times the surrounding volume. How wide around the target? 5 millimeters to a centimeter may not always be possible. How much energy do you need to treat once or twice? What should the power settings be? This is mainly empiric and warrants further evaluation. And the need, for example, for ongoing biopsies focal therapy has been called surveillance plus, because you need to continue to survey the contralateral side, biopsy it periodically, at least image it periodically, and stratify the frequency of biopsies accordingly. So finally, current management protocol, surveillance versus focal therapy. We do an MRI within the first year if they haven't had it already particularly, but really on both groups. Biopsy, confirmatory biopsy within a year in the surveillance cohort. Most groups are still mandating this. We do the same with the HIFU, or the focal therapy population. I'm mainly a HIFU treating physician, so my apologies for that. There is been some modeling done by Ruth Etzione's group that you can defer that confirmatory 1-year biopsy to 3 years with essentially almost no adverse consequences. And patients certainly are happy to defer the biopsy if they can do so safely. I don't think this is caught on, but it's compelling. And then MRI every 2 to 3 years in both groups, targeted biopsy if there's any change, repeat systematic biopsy every 4 to 5 years, regardless of the other parameters, and intervention for grade progression in the surveillance cohort, intervention for persistent clinically significant cancer. So it's remarkably analogous, the two strategies. So the future of focal therapy, we're going to hear more about this, but I think patients are going to increasingly demand it. I really believe the pushback against focal therapy as a principle will and should disappear, and patients are going to drive that because the quality of life benefits are so compelling. Increasing role of molecular biomarkers into patient selection, probably liquid more than tissue. Matching of lesion to the energy type. This is an embryonic field. We are really only now learning that perhaps, for example, electroporation for anterior cancers has been suggested, cryo for apical, HIFU for posterior lesions, TULSA for large glands. Practically speaking, most people aren't going to be able to offer all of these therapies. People develop expertise with 1 or 2 of them, and but I think clearly in the ideal world we will use the right treatment for the right patient. There's a mandate to confirm the oncologic effectiveness and safety, and this is, I think, going to be done with large-scale registries more so than with randomized trials, although there are several randomized trials being launched still trying to address the radical prostatectomy versus something else question. Determining which of these is best is a major challenge, and for the people here who are at the beginning of their career, there are so many studies to do here. Not difficult, really. Imagine randomizing a patient between 2 different energy-based focal therapy methods. You know, there's pretty much clinical equipoise. Of course, there are barriers to doing that kind of study, but they should be insurmountable. And finally, another major area for investigation is the symbiotic relationship, for example, between immunotherapy or AR pathway targeted agents to enhance the efficacy of the focal therapy. Very little has been done in this area. So my message is the ship has sailed. Focal is the new black. It's complementary to surveillance. These are different populations of patients, but it's obviously an important addition to our armamentarium. Thank you.